Hello, everyone. Greetings. This is Eric Laser. Welcome to our live recording of Bright Spots in Healthcare. That show is produced by Shared Purpose Connect. Each episode, we bring leaders together to inform our audience and unearth bright spots, successes at health plans, hospital systems, and other healthcare-related organizations around the globe. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the ideas shared during this episode can be applied at your organization. We believe that this strategy of finding a bright spot and cloning it is the most effective way to improve healthcare in our lifetime. Today's episode is entitled Behavioral Focused Care, Innovative Approaches to Healthcare Decision-Making, and is supported by our friends at MedOrion. If you have not heard of MedOrion, they are helping health plans and value-based care organizations change medical behavior across your entire population to improve the lives of millions of individuals. And that's a key term in their approach. Their technology combines behavioral science and artificial intelligence to create a unique understanding or profile of each one of your members. And then you use this data to take action to activate behavior that results in better healthcare outcomes. I will tell you a little bit more about them later on in today's show, but you can check them out right now at medorion.com. That's MEDORION, one word, .com. So thanks to those guys for being part of the Bright Spots in Healthcare family. If you have not subscribed to the podcast, you absolutely must. This allows you to get all these episodes downloaded onto your tablet or phone. Spotify, Stitcher, Apple, Google Play, whatever you use, Apple, Amazon, whatever you use to listen to shows, we're there. All kinds of big time guests from all over the industry, including the illustrious panel you see in front of you today. So really encourage you to subscribe, listen to some of the episodes throughout the year. We've had some incredible guests, including CEOs of companies, former cabinet members in the U.S. government, and a lots of other leaders at health plans and health systems. So check out Bright Spots in Healthcare. All right, we have a ton to cover. We have a couple of other panelists who are going to be joining us from all over the country here. So they'll be calling in. We're gonna have 5 panelists in total, we believe. And I want to get into it because we're going to be really tight on time. Those who are regulars know I'm pretty good at starting on time and ending on time. Today will certainly put me to the test. So I want to start with Dre Wallace. Dre, I know you represent an organization called Emergent Holdings. I'm going to want you to take a minute to let everyone understand who they are and what that relationship is with BlueCross, BlueShield in Michigan. And what I really want to start our conversation with is how health plans can convert their overall population-based care competency to individualized based care, because I think that's going to be the foundation of everything that we're going to talk about over the next 55 minutes here. So go ahead, Dre.
Yeah, sure thing. So a little bit about Emergent Holdings. Emergent Holdings is just that, the holding company that actually has quite a few other insurtech and healthcare related companies sort of underneath it. One of those companies is a company called AdvantageShare that does tech products for health plans like back office support, claims processing, enrollment, things like that. And then we also have another company that rolls up under Emergent Holdings, an entity that's called Senior Health Services. And so Senior Health Services is really sort of the MA arm for BlueCross, BlueShield of Michigan. And so the group that I currently work in is called the Business Lab, and we primarily focus on innovation and product development in that MA space, just thinking of different ways to be able to improve member engagement, risk and quality, type things like that. But to just quickly jump into the second part of your question, around like how you increase the competency of these things. Our team was a relatively new team, so we definitely had to evangelize a lot, within the organization. And the biggest thing that we really had to start to focus on was like really focusing on real problem solving, and also just being super focused on customers and members, like laser focused on that. And mostly the reason is because in order to try to reach a lot of people and to get them to do something, doesn't matter what that something is, to reach them at scale, you do kind of have to understand the individual, which means you have to look at the data. So that was one of the big competencies that we really had to get, folks kind of working around, is this idea of, we're sitting on all of this data, like, why aren't we using it to the best of our ability to be able to talk to members like we know them?
Could you provide a quick example of how you put it to the test? I know when we were talking the other day in preparation for this, you were talking a little bit about sort of age in into Medicare. Could you provide that example just so people could kind of get in their mind's eye what it's all about?
Yeah, sure. Much like, trying to acquire a customer for anything, any company, is not that much different really, for us. Like, so if we're trying to attack a problem, like member acquisition for folks who are aging into Medicare, in this case, it was for folks who we knew already. Like, these were, sometimes people who have been, maybe on a commercial plan with us for 20, 30 years, but, then as they were aging into Medicare, we were losing them. Like, they were completely dropping out of the funnel. So again, it's like kind of switching from, we can't just look at this as like, just kind of like attacking it as one big problem all at once, but instead these are all individuals. So we really need to understand, how can we segment these audiences in a way that makes sense? So we're actually attacking certain decision points and decision factors, things that would make them change their mind and motivate them to do a specific action. And in this case, that action is buying an MA plan.
Interesting, very, very interesting. We'll come back to Dre in a little bit. Just so you folks know, because we're so packed, we're gonna post the bios of everyone in the chat. So that way you don't have to, you get an understanding of all the great expertise everyone has, but we're not going to spend 10 minutes talking about bios, because we want to get them talking to us about examples that we could potentially take back to our organization. So that was a quick PSA. Also, one of our panelists is just on the phone. So if you're on Zoom and you're watching us right now on video, Alex Morehouse, who's the Chief Marketing Officer of Banner Health out in Arizona, is on the phone because her Zoom's being blocked by her firewall. So just so you know, we have all 5 folks here. All right, let's move over to Eve Gelb. She's the Senior Vice President of Member and Community Health at SCAN Health Plan, which I'm sure many of you know. And Eve, how are you applying sort of this human-centric design at SCAN today? How's that working out?
Yeah, well, thanks. And Dre, super interesting what you were saying about all the data that we sit upon, and how do we use it. And so I think that was also one of our starting places. But SCAN is a senior focused organization. We were founded by 12 we like to call them angry seniors in Long Beach, California, who were sick and tired of how hard it was to get the things that they needed to live their independent lives, live in their homes. They were being forced into nursing homes. They needed things like transportation, food, housing, all of the things that today, are our buzzwords for SDOH. And so we actually started at the individual level. And one of our struggles was, how do we get to a population level from our individual level where we started 47 years ago as a social services organization. But as an MA plan, we have a ton of data, and we operate a lot of special needs plans, which is a particular type of Medicare Advantage plan. And a health risk assessment is required. And so we said, okay, well, let's do the health risk assessment, not just on our MA plan, but also on our not just on our SNP, but on our full population, and use that data in our algorithms, our AI, et cetera. But that helps you identify your areas of focus. It doesn't help you solve the problem, right? Because behavioral science, behavioral economics, behavioral theory doesn't come across in the kind of data that you get as a health plan. So we really focused on a human-centered design approach, where we spend a lot of time already in the homes of our members, because when you're dealing with long-term services and supports, that's where you are, what their home environment looks like. We spend a lot of time in the home already, as I said. So we've really taken the approach of doing in-depth ethnographic interviews about our problem spots, like pain. How pain impacts the life of seniors, how it impacts their healthcare, how it impacts their outcomes is a really important topic. You don't get that from a survey. You don't get that from talking to somebody, but you get it from visiting their home and seeing how pain impacts their daily life and having a deep interview with them. So we do the data analytics to find the problem. We do deep ethnographic interviews with folks who are trained in how to do that and can develop rapport. And then we bring those ideas inside. We brainstorm, we create these things called sacrificial concepts because we might have an insight, but it creates an idea that then we have to be willing to sacrifice. We have to go and test with our population. So we take it back out to a different set of older adults, people on the fringes who pain is not impacting their life or pain is really impacting their life, and see, do they think our idea of a pain care navigator is a good idea? Do they think the idea of CBD oil as part of our benefit is a good idea? Like really testing the ideas that we or experts might come up with. And then we look at, okay, which are the things that are successful? We prototype, we pilot, and then we can scale them. So it's really like, how do you get deep into the life of the person you're trying to help?
It's great. I love that. I love that whole strategic approach from even to execution. I want to fly over to the East Coast now of the country here and bring in Trip Jennings. He's the Innovation Officer and Vice President at BlueCross BlueShield South Carolina. Trip, how is your organization approaching the individualization, if I may use that term, of population health and driving better participatory medicine in general?
Yeah, I think quite simply, many of the things that we went through in the House of Medicine probably 15 years ago, where there was a big push to stop calling patients by their diseases, got a 35-year-old diabetic in room through 50. It was interesting when had already been working kind of on the insurance side for the government, but coming over to commercial, I realized that a lot of our processes were designed the same way. And so we were evaluating people just off of their claims. And one of the big challenges is, and something we say all the time is, the absence of a claim does not mean the absence of a disease. So how can we get closer to understanding who these humans are is the first step. No one wants to be contacted by someone that they don't know or that they don't think knows them. And so the first big push we did was to really get bedside clinicians involved and engaged, those that understood what it was like and what the members were going through, what the patients were going through. That was the first big test for me to start saying members instead of patients, because hopefully we can keep them from being patients. But the second piece of that is really, taking the data carefully and starting to better align that with who the individual is. And so, if you tell me, again, there's a 35-year-old diabetic in room 335, I can come up and look at the labs and figure out kind of a game plan, but how to execute that, you've got to go meet that person. You got to talk to that person, understand who they are, understand what their social risk factors are. And so without that information, you're just throwing stuff at a wall. So our plan has really been to, again, get bedside clinicians that understand what it's like, bring in other assets of data so that we can get a better picture of an individual, not just after the fact, looking in the rearview mirror with a claim, and then tailoring not only their care and their plan, but their outreach so that they actually, if you send me an email, there's a high likelihood it's going to take me 48 hours to get back to you. If you text me, I'm going to get it like that. Not everybody's that way, but members are humans. And so we got to figure out how to get in touch with them the way they want to be contacted.
And I'll now bring in it's a nice transition to the clinicians. And by the way, Trip is a physician by training. And so we're going to transfer over. We're talking about bedside. Let's go over to the provider side entirely for a moment and have Alex Morehouse come in. She's, as I mentioned earlier, the Chief Marketing Officer at Banner Health. They're a 30 plus hospital system out in Arizona in the western region of the United States, based in Phoenix. Alex, what best helps the consumer to be empowered in managing their own healthcare needs?
Thank you. I'm glad to join you this morning. And what best empowers consumers is giving them digital tools to manage their own health and to access the healthcare system. So every health system in the country is struggling with staffing. There aren't enough doctors, nurses, and APPs. So if we can allow consumers to, one, get some information through digital tools rather than in an office from their provider, and if we can help them with screenings. So it's probably easier if I give you an example. So let's say you're living with some cardiac issues, or you suspect you have some cardiac issues. So we have a full digital library of heart information available. Most accessed and most used are interviews. We have found the format that's between 4 to 6 minutes. If we have our various cardiologists, and there are all sorts of specialists within cardiology, we have those interviews available. We also have a heart risk assessment. So it's basically a quiz that you can go through if you think you're living with heart disease. We have this quiz set up so at the end note, it says, hey, just manage your weight and your exercise, or you probably should schedule a office visit with a cardiologist. That directly leads you into our Find a Doctor tool, which will indicate a cardiologist near you in your neighborhood. And then it immediately takes you to a self-scheduling tool, which is like OpenTable. And so you've gone through, you've done your heart risk assessment, and you say, oh gosh, I actually do need to see a cardiologist. I choose one who's in my neighborhood, who maybe speaks Spanish, and I can go directly into scheduling with them. Additionally, we have tools like a symptom checker. So if you think you're having a heart attack, for example, you can go through this chatbot and you can quickly, before you ever get to the ER, you can actually check and see, all right, is this happening or is it just heartburn? And it will indicate if you actually need to go to the ER, or you can wait and schedule an appointment the coming week. And if you have already been diagnosed with heart disease, then, for example, we will reach out to you on an individual basis and say, boy, it's been a while since you've seen your cardiologist. Do you want to come in and make a visit? So this was particularly important during COVID, when everybody was staying at home, and particular people who had health conditions, and especially so prior to the vaccine. We had a very serious issue with people who were active cardiac patients who needed to get in and see their cardiologist. The clinics had made it extremely safe. They would only see one patient at a time. They had wait in your car in the parking lot until you're ready. You get a text, you come in, you never actually have to talk to the receptionist. But our cardiac patients didn't know that. And so we had to check and say, oh, Alex hasn't been in. Alex has a cardiac issue. She needs to come in. So reaching out like that. So we used a whole variety of digital tools to either pre-diagnosis, give you information. If you're having an incident in the moment, to give you a symptom checker. We also have a nurse hotline if you want to actually talk to a nurse. And then once you're a patient who is being monitored over time, we have a number of digital outreach tools to make sure that people are maintaining their health care.
So what's interesting here is, so you've invested a lot in digital, I'll call it self-help digital content to support the member, and you've obviously carefully journey mapped the member experience. Are you using any data or any tools that are new to activate that member into the journey, right? The journey mapping process seems really important. It seems like it's been very well thought out, but what if we don't get them to the journey? How's that happening?
Well, that's where we produce rich content, and we use that as the bait, if you will. And typically the trade-off is we want an email address, and most consumers understand, okay, if I give you an email address, you're going to reach out to me. We make it voluntary and say, would you like to hear more about cardiac issues? We have a very high take rate on that. And then we have this whole array of places where they can engage. We use each of those as a touch point, and that's another way to bring them into actually seeing a cardiologist. So we use each of those tools and a variety of technologies. Each of them is a different vendor partner that we use, but each of them are used to actually get people to engage in their healthcare.
Gotcha. I'm going to bring back in. Thank you. I'm going to bring back in Dre Wallace. Dre, how are health plans and how is your support sort of in partnership with Blue Cross Blue Shield of Michigan? How are you best measuring which individuals you should engage? And once you do that, how are you figuring out how to make it personalized enough that they actually do engage?
Yeah. So again, like it's sort of, we try to use other examples sometimes that are just outside of healthcare because other industries are just a lot further along. So, we're always trying to reach, consumers. But in our case, like everyone is either falls into one of two categories. Either you're a member we already know, or a prospective member who we don't know yet. But either way, in order to either get to know the people we already know, a little bit better, we're still looking at the data, and more than likely, even for prospects, we're still trying to acquire data, from other different sources. So really, it's like trying to think through, like, how would I want to be talked to if I'm a consumer, that there might be a specific product, that I'm looking for, because this really isn't any different. And really customer expectations aren't any different. We talk often inside of the org when we're trying to discuss like some of these concepts, and we use, things like Netflix and Amazon and Spotify as examples, because they're things that people already understand, that they're using all of this data, things that they might know about you, and also ways that you've interacted with some of these platforms, and then basically taking that and saying, okay, I'm going to give you back what we believe you need. And it seems to be a pretty, easy example to understand. And so it's not really any different, for healthcare. Like, for example, if we're trying to attack something like, closing gaps in care, something that is very, related and near and dear to, star ratings and everything like that. If we're trying to get a person to do a thing, like go to a screening, get a test, something like that, then we need to understand what are the decision factors that might be holding them back in the first place, and what are the things that might be something that we could say, in some of the rich content, the things that that you guys have all been talking about, is having that content, almost using it as bait. So you get the opportunity to communicate with them in a way that should resonate with them because you know about them, because you've looked at the data. So we've been trying to use those techniques, with things like medication adherence, stuff like that, just to make sure that, like, once we have these folks, that we keep them healthy, and hopefully out of the hospital.
Great. I actually want to come back to the other industries. Those of you who are regulars in the show know I'm fascinated with just how little we do benchmarking off other industries, especially in retail. I want to bring in, before we go there, I want to bring in sort of I'll label him our in-house, tech data guru. He is Shai Levy. He is the Chief Operating Officer at MetaRiot. And Shai, how we've been talking about, so everyone's provided some interesting examples of how they're going about activating and engaging, but how do you do it at scale? Like, if you're a big health plan with 1 million fully insured and another 1 million ASO members, I mean, how do you go about understanding why people are going to be able to act in a certain way, understand all of that, be able to take action on it, but do it at such a large scale effectively?
Sure. And first of all, thanks for having me on the show. I'm really excited. I think from my perspective, there are 4 things that are key. One is behavioral AI, and I'll talk a little bit about what that means: infrastructure, governance, and measurement. And let me walk through those things maybe with a story that you can relate to. Think about a member that's taking their statins to manage their cholesterol, and you have an AI in place that tells you this member is 60% likely to refill his next prescription on time. And so what do? You want to improve those outcomes, but all you know is 60% probability to take action. And what do? You send out a nudge, a reminder, maybe direct mail or a text message, say, hey, you're overdue, refill your drugs. What if I told you that within his clinical record, you could see that he used to take his statins all the time, but recently his physician has changed his dosage. And with that specific brand of statin, that could lead to a side effect. And our member's a bit shy. and he doesn't want to bring it up with his doctor, and he's staying on his old dose. He's not taking the entire dosage, and it looks like he's, non-adherent because he's not taking the doses the way he's supposed to. Now, if you knew that he's having a side effect, you could target that and hopefully remove that barrier to action and put in a call to action that's effective. But you can't go into that granularity of evaluating each member record. And that's where AI comes into play. But the difference with behavioral AI is, rather than tasking it with telling me what is the probability that this member is going to refill his prescription, you want to ask it, why is this outcome, right? So once you understand why, you can use that insight to change that behavior. Now, the second thing is you want to wrap that with infrastructure, because we're talking about scale, right? So you want to be able to automate the data going into this AI, so it's constantly using the most up-to-date data that it has. But you also want to wrap it with APIs so that you can use these insights within multiple touch points in your organization. So it doesn't stay siloed, you're not sitting on it, but you're actually applying it. And that's where infrastructure comes into play. And I think using API is a good way, because it doesn't require you to change your existing workflows. It just allows you to ingest these insights and benefit from them when you're engaging the member. Now, because we're talking about AI and automation, and because statins is just one problem, you have vaccinations and screenings and annual wellness visits. There's a lot of these different things. You don't want to bombard your member with all these messages. That's where governance comes in. You can govern how many times do you want to touch this member over the course of the year. What is your business priority? What are your goals? That allows the AI to both create a process that you have governed in terms of the member experience, but also prioritize your business KPIs and targets. And I think finally, it's measurement. And the key with measurement, you want to see that this is effective, that this is actually increasing the probability of a positive outcome. So you want to bake a test and control group into this to be able to say, this is effective, this is working. And that altogether will get you to scale.
Great, that's great. I want to come back to you in a moment. I think this is actually a good segue for two things. First, I want Sherry Kills, our producer, has reminded everyone they could ask questions through the Q&A module. At this point, hopefully everyone's pretty familiar with Zoom. You can find that on the bottom sort of left of your interface. I told you guys we're really packed. I will do my best to integrate some of these questions into the flow of the conversation. Maybe we have some extra change at the end of the show. I could throw a couple more in, but I'm not optimistic, but we'll see, because we have a lot of great stuff coming up for you. I also told everyone that today's episode was supported by MetaRyan, which is Shai's employer. I did want to tell you a little bit more about them, because one of the cool things about doing this show for now just about 8 years is we've earned the privilege of being able to find experts in the areas that we want to cover for all of you in the audience that also want to support the show. And these guys, if you haven't got it just from just hearing Shai talk, are really exceptional in their combination of tech and marketing prowess. They understand that people's behavior and decision-making processes are among the keys to determining their health over time. And so they take the psychological motivation behind people's decisions and understand how this is going to help enhance their overall behavioral and population health. So what they do, and you heard a little bit about this just now, is they combine behavioral science and AI capabilities to create this human understanding at scale, which is super unique. I just haven't heard a lot of organizations taking this kind of aggressive technical approach that I believe a lot of the other industries that we consume all the time are already doing this. So they take behavioral-based insights and they use their behavioral intelligence software to provide health plans and risk-bearing organizations an in-depth understanding of a consumer's and their concerns. You just heard how that example with the medical adherence, and they enable that health plan or other consumer risk-bearing organization, ACO, to personalize and automate one-on-one member conversations at scale, and then facilitate those interactions to drive better healthcare delivery and, of course, better financial outcomes. It's really cool stuff. They have, so as part of just my interactions with them and my planning with them and my vetting of this organization, they share with me a lot of their research and their content. I am not always big on distributing white papers. This white paper they have is called Care Health to Intelligence Consumer for Business to Consumer. And it is a really good detailed case study of how you could apply intelligence to business to consumer engagement and marketing. So if you guys want to review that, rather than have to go on a website and fill out a form, I'll send it to you directly. Sherry's going to put up a poll, and if you want that, we will send it to you. There's also an article that I found in my own research in the journal Integrated Healthcare Executive, which is this very interesting online journal that I recommend. And there's an article and an opinion piece by Shy's CEO and founder, Asaf Kleinbort, and it's called Behavioral Focused Care, The Next Frontier. It's also a really interesting piece, and I'll send you directly the link to that in that email too. So request a white paper, I'll send you both pieces. I just think it's a quick read. They're both quick reads, and it could give you a sense if you want to do something differently, or at least explore things differently at your organization. I think it's well worth it. And if you do just want to check out their website, it's medorion.com. Go spelled exactly how it sounds, medorion.com, one word. I'm going to move on now to the flow of the conversation here and bring back Eve Gelb. Eve, I want to do some examples, and Chip, I'm going to put you on deck here. So stretch out. I'm in baseball mode too after my Red Sox got beat up yesterday, but I'm not giving up hope. So Chip, you're on deck, start swinging. Eve, how could you provide an example of how you guys at SCAN are taking this data-driven approach that we've been talking to and applying it to do something productive and meaningful with your member population?
Yeah, sure. So we are using AI as well. I think probably not to the level of the behavioral AI that Shy is talking about. So that's super fascinating to me. But we are doing it to identify the people who have the problem, not why the problem exists. And like some of the problems, preventable hospitalizations, right? There are a lot of models that drive you to who's going to be admitted, but we're looking at who's going to be admitted for a UI, right? For an infection, a urinary infection. That's a different set of models than who's going to be admitted for a cardiac infection. And it really has to do with things around frailty, around activities of daily living, the kinds of data that exist in a health risk assessment and don't exist in a usual electronic medical record. We also have models that are helping us identify people who are in need of long-term services and supports, right? We're going to find them our own way when we talk to them on the phone, but those people that we can't. But one of the most interesting places where we're trying to go, we haven't built the model yet, it's called Finding Dorothy, right? So Dorothy is a pseudonym for a person who does not have a ton of self-efficacy in the health system. And she's a woman who went to her doctor because she's diabetic. She's afraid of her foot being amputated because her sister's foot was amputated, and she's seeing, some blackness on her toes, but her doctor is rude to her. And so she's like, okay, I'm not going to the doctor anymore. This person is impacted by her life. She's grew up in a low income environment. She's got a lot of health problems, a lot of barriers to getting help, but she also has health literacy issues, and the health system is not treating her, to Dre's point, like a customer that really matters. And so she is shutting down and changing her behavior. This is the kind of person it's really hard for us to find timely. So we're trying to use AI models to say, is there something about the way people answer the question, how do I rate my health compared to others my age? Is there something about the fact that she's a person who uses our transportation for our benefit? How do we find the Dorothys? Because they are the people, to the point that Alex was making, there are tons of people who could use the digital model. She cannot use the digital model. How do we find her so that our human resources are dedicated to people like her?
That's good. It's a great story. Fine. And is there any? Do you guys publish anything about Finding Dorothy, or no?
So we have not yet published anything about Finding Dorothy. Most of our models that we're developing, we're developing for our own business use case. We're not doing them in any research mode. So we've not published anything about Finding Dorothy yet.
Trip, how is BlueCross Blue Shield of South Carolina taking a data-driven approach to all of this?
Yeah, so starting a couple years ago, we wanted to look at a different way of segmenting a population and prescribing an intervention. So pretty much all plans You know, just pick diabetes again and say, let's stratify the population off of whatever that has diabetes, put them in high, medium, low risk. For high, we're going to do this. For medium, we're going to do that. Well, as an example, just one of the groups that I'm blessed to get to take care of and to oversee has 40,000 diabetics. So if you stratify 40,000 diabetics in that population, you're really not that much closer to understanding who those 10,000 are that are high risk. And so I don't want to overblow this in any way, because this is really pretty simple. And my data scientists always say the algorithms are easy. You know, you do need to test them. You need to test them to the outcome. The hard part is the intervention and aligning the intervention with the person. So the first thing we did is just use the massive amount of data that we had. And similar to what Eve was saying, was really get to the point of using a surrogate for worsening disease, which in many cases, but not always, is admission. And so we had test data. We have so much data that we're able to then go back and compare that to a population real time. So as more members come on or as other claims come in, we're constantly running that. And we could segment those into a different way of looking at them with high, medium, low, based off of area under the curve, who's likely going to be admitted. What we found was really interesting. So one of the individuals who's an awesome nurse brought over to start implementing some of these new plans and new processes. She started just calling and reaching out to those that were the high risk, but were not admitted yet. We didn't think. What we found out is of the first, it was like 50 people that she called, 40 of them were already in the hospital. We just didn't have the claim yet. We didn't know about it. And so it was like, whew. So this trend went on to the point where we realized we need to go down the spectrum and really look at what everybody says is that rising risk and reach out to them before they start to move up. Makes common sense. I know everybody's heard that before, but it was a different way of utilizing the data, because we weren't just using claims. So we were bringing in medication adherence, medication possession ratio, laboratory data. Even if we hadn't heard from them in a long period of time, if they hadn't called customer service or they hadn't renewed some of their logins and those types of things, just to see if they were kind of falling off the radar. Cutting to the chase, everybody knows this, but when we got in touch with those individuals, which by the way, they were about 10 times more activated than those that, were just clicking along, their A1C is climbing, but they don't have any symptoms, nothing else is going on. These individuals that were that medium to high risk, they actually would answer the phone. They would respond because they knew something was going on. And almost every single time it was social determinants of health. That was the big reason. They didn't need a flyer on how to take their medications. They didn't need a new doctor. They had a doctor. They needed tires for their cars. They needed all these things that we talk about. And their neighbor could have told you. And so just trying to get a better segmentation of the population. And we call this tool, we actually were going to use it initially to test it out. We tested it out on some large employer groups. And we're thinking about using it as a buy-up, but then it was so effective that we said, and the reason it was a buy-up was because we had to put so many human capital on this for the intervention. It's just how we run our business now. So that's what we call precision care solutions. And it is underpinning all of our care management processes. So the next step of that, and we've been talking with Meta Ryan as well, is to look at how do we improve that engagement even further. We have a preference center like many do as far as text or phone call or whatever. But I think the analogy and the simile to Netflix is huge in the fact that, it serves up something similar to what you've been watching. And if you don't like it, you can say, don't recommend this anymore. And we need to get more and more of that into healthcare so that we can get people what they want, how they want it.
That was in the producer world, that's a great tee up to the next question, a great transition. First of all, I know you're already talking about it, Ryan. That's cool. But my next question is really around taking a data-driven approach, similar to Netflix, Amazon, Google. They're so successful with that. How can we do that in healthcare? And if we could provide some examples to how we're doing that in healthcare. So I was going to bring in Shai Levy, bring him back in to talk a little bit about that. And Alex, I'll put you on deck. Go ahead, Shai.
Sure. So I think first thing we need to think about is HIPAA, right? Because HIPAA dictates basically what we can do with healthcare data. And we need to think as covered entities and business associates that we can use the data for different purposes, like clinical quality improvement. I have a guest here. So,
I love this.
I think, yeah, this sometimes happens. I'll keep going though. Charity. So I think once we have HIPAA in mind, I think the first thing that comes to mind is what Trip talked about. How do you use data, or how do you classify members that you don't have any claims for them, right? And what a lot of social and B2C organizations, e-commerce does is a lot of lookalike, right? And that's the first thing that we're adopting from that. How do you classify a member that you don't have any claims for, don't have enough claims for, because they're new on the plan, because they don't use their healthcare a lot? And so a lot of lookalike techniques, looking at the similarity between members that you are rich in data for, and you can classify them well based on your algorithms, and doing similarities and lookalikes with members that you can't do that for. Second thing that I think we bring in is the ability to use these insights everywhere. And you feel it with e-commerce when you go on a website and you're looking for travel, and then you go on Facebook and suddenly bookings is right there with you. And I think that tactic doesn't really suit healthcare, but the strategy does. Use these insights everywhere. So if you know something about a member, use this when you send out direct mail. Use this when your care coordinator reaches out. Give this hint to the care coordinator to say, hey, there's something that you might want to uncover. And I think the last thing, and I saw this in the Q&A, is how accurate is your AI? And I think a lot of things that they're doing in e-commerce, they're at like the cutting edge of data science, and they're bringing in different types of measurements. One of them is uplift modeling, which basically tells you how well are my interventions doing in terms of improving outcomes. And I think one of the cool things that we've done is incorporate that into healthcare. So we can tell who we're able to persuade. Once a campaign starts running and we start to engage members, we can tell who we can persuade and who we can't persuade. And if I go to that with medication adherence, and I think why that's really cool, imagine that you're running this barrier removal strategy. You're trying to remove barriers like cost or side effects or just a sense of urgency to take drugs. And some people are responding, but other people aren't responding. For the core competency for barrier removal is that person wants to take the drug in the first place. And with this type of AI technique, you can see that it's not working for other people. It's not increasing the probability. These people don't want to take their medication. So now I know who they are, and I can retarget them with a more effective strategy. And that's what leads to year-over-year improvement. And I think it also answers some of the Q&A process for biases in the algorithm, because you can measure, does it have a business impact? Does it have an uplift in the probability to improve the outcome, yes or no? And I think that's these are a few things that we're bringing from e-commerce into healthcare.
That's great. By the way, your daughter's adorable. Bring her on the show anytime. And great concentration, by the way. That was impressive.
I've experienced in that. Not my first time.
Alex, how about over at Banner? How are you taking sort of a consumer Netflixy approach to data-driven marketing?
First of all, I'm delighted to hear the personalization that we're observing across each of the speakers. It's no longer the diabetes patient in room 10. And we have Dorothy. You've given Dorothy a name. We use the same thing. We have a persona, and we call her Sophia. And she's married. She has a couple of kids. She has 4 sets of parents that she's looking after. And she's basically short on time and short on money. So everything we do is trying to collect information about her and then using if-then logic. AI is basically just math, and it's all this if-then logic. There's nothing fancy about it. It's been around for ages. But the most important thing is pulling all the data into a single place. Most health systems think that they already have all of customer data in a single place, and they call it their EMR. That is a very partial view. It's at best half of the picture, because all the service interactions need to be there, billing needs to be there. How often did she log in? What content did she look at? How many times did she call into the call center? What's her health history over the past 18 months? And also, P.S., who are her family members that she's looking after, which is why we deliberately chose somebody who had an extended family for whose health they were responsible. So the first thing we had to do was extract data from, I think we had 120 legacy systems, and put it into a centralized customer database with a 360 view of Sophia And then every single interaction, the most basic, we put the preference data in there, but everything is firing off of an if then. And particularly with the new cookie regulations that are coming in where you cannot use third-party data, having primary transaction data is what drives all of our interactions. So we have personalized transactions with 3.2 million Sophias, and it is completely specific. Every interaction, every communication, the content that she served on the website, the digital tools that she offered, all of them are personalized based on her data profile. And any place she shows up across the system, because we have everything from urgent care and labs and rehab to clinics to acute care to hospitals, any place she shows up, the right hand and the left hand know what has happened the prior day, the prior month. And so there's a consistent experience. So we're using the data on a day-to-day basis, on a patient-by-patient basis. And then we build that into our ROI model. Then we are very happy to see that there's a very robust payback for all of that.
Alex, I have a couple of quick follow-ups. So first of all, so did I hear you say like you can't prioritize all that great internal data, let's say maybe external data like zip code? You're not allowed to do that by just technical limitations or by the law?
No, the new data, it won't go into place for another year, but the example that was just given, you start to research travel online and then Facebook is going to start serving you ads for bookings.com. They will no longer be able to do that. So you can't use, that's what I call third party data. You can't use Facebook tracking data. So the digital footprint that basically you can't use your browsing history to serve personalized ads anymore after 2023.
Right, but are you able to leverage, let's say, holistic social determinant data like zip code to overlay and hone in on the Sophias that are going to need the most help and require the most timely intervention?
Yes, of course. And we use demographics. We use that third-party data. It's Experian, Prism, choose your weapon. It's all publicly available, and we do use that.
Got it. And a couple of other, I have a follow-up myself, and then some audience questions are coming in. I think we could grab one of them at least. As far as that sounds like a daunting 120 database sources or data sources I heard you say into one. One, how long did that take? And two, is it a homemade database CRM, or did you take one that we would all be familiar with?
No, I would never ever recommend a homemade. It will fail. I promise you, it will fail. So it took about 5 years, a couple $100,000, and we had to, in order to get that cash, we had to do the ROI, but it has had a very robust payback because we get more patients in the door, we get them more engaged, and they stay longer.
I mean, a couple $100,000 seems really low. I'm surprised to hear that. I was thinking.
Sorry,
Really
sorry, it wasn't 100,000, 100 million. $200 million.
Okay, that sounds.
Yep.
That sounds more like it. All right, yeah, that's a massive undertaking. Okay, great. Now, so I think we had a question for you about. Could you say more about the new cookie restrictions? But I think you did upon follow-up. There, so I'm going to assume we answered that. Just going back to your first answer about 20 minutes ago around your tools, Arielle wants to know how has been the consumer uptake of those digital tools, and have you been able to garner through utilization any insights about, how to facilitate the appropriate use or good use of these tools?
Well, let me give you an example. Our uptake of those tools is typically measured through the usage of Google My Business, because that's the digital front door. When people sit down in front of a browser, do they go to your Google My Business listing or do they not? So before we started this series of implementations and investments, we had 3 million people a year coming to Google My Business. This year we will break 160 million people coming to Google My Business. And 68% of the people who come in and book appointments through that are new to Banner. They've never been Banner patients before. So if you build it and make it easy enough, they will come in droves. And we pursue the one-click strategy. So we buy all the keywords. If anybody's on Google putting symptoms in, abdominal pain, sprained ankle, they will immediately go to the Find a Doctor tool, which immediately takes them to a booking tool. And that has driven this 160 million new visitors.
That's great. That's member journey at its finest. I want to, guys, we're going to do some ROI talk in just a moment. So hang on. And Alex, I'm going to bring you back for that. I want to talk a little bit about this data-driven approach as it relates to the pandemic. We haven't said the C word once yet, but I do think it's worth noting because we're certainly still in operations around getting folks tested, getting folks vaccinated, getting folks treated. So Shai, could you talk a little bit about how this back-end individualized approach to population health has been working and how have you been applying it during the pandemic?
So I think the first thing that happens in the pandemic, right, is when you look at data, it starts moving in a really, really significant way. And with one of the plans that we were working at, what we found out was, and I have a guest back here. What we found out was.
By the way, Dre, I'm going to want you to jump in on this too, because I know you were actively involved in this. So when Shai needs help, you jump in, right?
So one of the things that we found out was that members, Medicare eligible group members, were dropping their coverage. And your predictive analytics is telling you, oh, there's a risk for enrollment rate towards the end of the year. And the behavioral AI, the explanatory AI is telling you knowledge gap. What does knowledge gap mean? And we thought about this for a little bit and we figured out, wait a minute, these people aren't dropping their coverage, they're losing their jobs, or they're afraid to go into work because they might get sick and they feel like they're forced into retirement. Okay, so now they have a knowledge gap and what do I do in terms of coverage right now? And so we quickly iterated on that and send out a message around the special enrollment period and their eligibility and what they should do. And that, put the data on trend right back. And another example, again, from the medication adherence space was we saw med adherence rates go down. And then again, the probability AI says, risk to meeting the goals towards the end of the year, but the explanatory AI says logistical issues, right? So you think about what does that mean? It means people don't want to go to the pharmacy and pick up their drugs because they're afraid of the pandemic. And we're talking about like the onset of the pandemic. And so you want to come in with messages that are helpful. And the plan that we were working with said, we are going to make 90-day refills more accessible. We're going to help people with home delivery. And then we can take these solutions that the plan has already made, but we can match them to the right people that really need them, right? And you can do that really, really quickly because you have the ability to interpret why the data is fluctuating, not just the risk of the data fluctuating. So those are a couple of things that we did with the pandemic.
Dre, is there anything to add there, what you guys were doing up in Michigan?
Yeah, sure. We actually, so MetaRyan is a partner of ours. And I think probably for us, the most remarkable thing about what we were able to do is just the speed in which that we could do it. So we've already sort of built this infrastructure of similar to what a couple other folks on here have talked about too, but this infrastructure of being able to have all your data centralized in one place. So we were already kind of set up, ready to go. So once the pandemic hit, we're working along with MetaRyan, we could quickly get something in market to be able to start talking to members to let them know, about special enrollment periods, trying to figure out which are the folks who are socially isolated that maybe need to have a kit, sent to them. So things like that, we were able to engage, within a matter of days, which, it was one of the things that actually was held up as a great example, even just, within our own organization, just this, the speed that we could get to market with it.
Right. All right. Trip, can we talk a little bit about how to get folks who are listening right now some ammunition on procuring investment for these kinds of individualized population health approaches? How do we rationalize the business case here? And what are maybe some things that have been proven out at BlueCross Blue Shield of South Carolina that you could share that could help sort of show that this is worthy of investing, hopefully invested in the right way?
Gosh, that is a great question. And I tell you, if I knew the answer and it was ironclad, then I would not have to work the rest of the day with these business cases that I have to pitch. But I'm going to tweak it a little bit because I don't think it's an investment in this topic or an investment in SDOH or an investment in, personalized medicine or personalized healthcare. I think the CEO of Microsoft said this early on in the pandemic, to come back to the C word, that they had seen 2 years of transformation, digital transformation in 2 months. I think we all felt that. The question that we're faced with, and that I think is very acute, is what do you invest in this space? Because we have not had any reluctance to invest in. It's just like, how far and where do you put the money? Do you put the money in data quality tools so that you can bring in all these new data assets? Do you put the money into a vendor? Do you put the money into staff, which is tricky, especially with this market the way it is now? So I think the question really is, and our approach has been, figure out what the biggest use case is, and don't make it too long, because if it is a long-term strategy at the pace that we're moving now, you will lose everybody, especially your leadership, because they're not looking for a 3-year return on investment. They're looking to see something in 6 months. And so you need to pick a use case where you can have something to turn around pretty quickly. And so what we've been trying to do is, I tell my team all the time, I'm extremely lazy. I don't like to do the same thing twice. Don't build anything or buy anything that we can't reuse for other things. And so I think that's maybe another tenet to look at as you go forward, just to say, before you purchase something, before you dive into something, make sure that you can build on it for other use cases.
So short-term and leverageable.
Correct.
Okay. Alex, let's go over sort of the chief marketing officer that has to live and breathe sort of ROI decision-making. How would you go about rationalizing some of these investments? Or to you, it's like you have to, and how do you do? And I think what Tripp said, figuring out the right places to go is really important. So I'll let you pontificate a bit.
Sure. It is good news because you don't have to guess. So digital transformation has been happening in retail and airlines and banking for 20 years. And there's a very consistent and invariable path of the things that you do in what sequence. And the software packages, you don't have to guess. The good news is you don't have to guess. And I got started, my first half of my career was at American Express, and we got so good at using customer data every time one of us pulls out a credit card that we started doing digital transformation for other companies. We did it for Wells and B of A and Nordstrom's and the Apple stores. And there's a cookbook. It's very straightforward. And it's you should never be buying a single package. There's a whole sequence of software packages that are very straightforward. And you put them together in a very predictable sequence, and you understand what the payback is, and that's what allows you to get your funding from, in my case, the board of directors.
Good stuff. We're just about out of time here. Eve, do you have final thoughts for us on this as far as investments and rationalizing investments and getting these?
Yeah, so like Tripp, I'm lazy, but I'm patient. So good ideas take, time to come around. So don't throw out your ideas is what I would say, because they come around. The other thing is, when you're investing in human resources, invest in people with lived experience. The reason, Google, YouTube, et cetera, are good is because they've hired the consumers. So in our world, we invest in hiring peers, people with lived experience, people who have community understanding, cultural understanding, linguistic competency. That's how you transform your structure in order to improve the outcomes for the population you serve. It helps you understand your population. And for us, studying the outcomes, to Shai's point about measurement, 5-star is the thing that drives us, quality outcomes, being able to demonstrate. Like, we have an amazing peer program called Member to Member. You're not going to talk to a 25-year-old English-speaking woman about urinary incontinence if you are an 87-year-old Latino, but you will speak to a peer about it. Somebody who speaks your language, is your age, is a male, and experiences those problems. So I think investing in people with lived experience is the place to go when you have to invest human resources.
We will end it at that. We're at the top of the hour, or the half hour of our top of the hour. I want to thank MetaRyan for supporting this episode. Check them out, metaryan.com. But our panel as a whole, the time you took to prepare with me, take the time out here in the beginning, were sort of pseudo middle of your day, thank you so much. And for all of you who are listening and watching live or through the podcast or through the website, thank you so much for taking the hour and trusting us with an hour of your day. We will see you at our next episode. This has been your Bright Spots in Healthcare podcast. Thank you very much, everyone.
Thank you, Eric.